I'll take you to another area, that is vascular interventions. And the case that I'm going to present is one of the very rare cases. As you know, Takayasu's arteritis is a very rare large vessel vasculitis affecting the aorta and its major branches. Here I present a case where this patient had pulmonary artery stenosis and was severely symptomatic, for which she needed further intervention. This was a 35-year-old female who presented with dyspnea on exertion for last 2 years. She was in NYHA class 3 and she had central cyanosis. She had past history of treated bone tuberculosis, which is important for this case. Patient also had upper limb and left carotid pulsations were not palpable. Right carotid was very feeble and there was a bruit on the right carotid. While the lower limb pulsations were well palpable, her ESR was raised and on echocardiogram showed the dilated right atrium with right ventricle and with PFO shunting from right to left. This was the digital subtraction angiogram of this patient. You can see here the left subclavian artery is totally occluded, the left common carotid artery is totally occluded, and the right common carotid artery has severe stenosis in this patient. So therefore, this patient has arteritis with affecting major the arch vessel branches, while the abdominal aorta and renals were normal. We took up this patient for further evaluation in view of her severe pulmonary artery hypertension and right to left shunting. The patient's right ventricular pressures and pulmonary artery pressures were elevated, and angiogram showed that patient had severe stenosis at the ostium of the right pulmonary artery. You can see here it is a very severe stenosis at the ostium of the right pulmonary artery stenosis. So then we took a 9F Mullins catheter over a guide wire, 3-5 extra support guide wire, and through the right femoral vein. And then from the main pulmonary artery, we passed a guide wire into the right pulmonary artery and found the gradient across the stenosis was 70 millimeters of mercury. Then we did intravascular ultrasound with a 12.5 megahertz catheter over the guide wire to see the pathology. This was the intravascular ultrasound image. You can see here dense transmural fibrosis from all the three layers of the pulmonary artery, from the intima to media to externa, all have severe dense transmural fibrosis. This is the only very small chink of narrowing left in this patient. Then we took up this patient for balloon angioplasty, and over the guide wire we passed a 7 millimeter balloon initially for pre-dilatation, and then we dilated, and then we dilated with the 10 millimeter balloon at 10 atmospheric pressure, though there was still a small neck at this origin. And after balloon dilatation, you can see here the lumen has widened. There is dissection of the intima. You can see here the intima is dissected, but the lumen has improved remarkably. And after that, this is what the balloon angioplasty was done, and you can see here initially there was a neck, and then after further inflammation the neck also disappeared. Then we deployed a stent because there was dissection. We deployed a stent across the severe stenosis, and then post-dilated the stent. The distal segment was post-dilated to flare up the stent. Distal and proximal segment both were flared up with the high pressure balloon dilatation in this patient. And you can see here, after balloon dilatation and stent implantation, you can see widely open the right pulmonary artery ostium, and you can see here the stent is completely well opposed to the wall of the pulmonary artery. The pressures, the oxygen saturation of the pre-angioplasty, the oxygen saturation was 86% peripheral oxygen saturation, arterial oxygen saturation, which improved immediately to 97%. The pulmonary artery pressure, the mean pulmonary artery pressure decreased from 52 millimeters of mercury to 30 millimeters of mercury, and the peak systolic gradient across the stenosis decreased from 70 millimeters to 12 millimeters across the stenosis. Also, we did the technetium lung perfusion scan in this patient. You can see here very well, the left side is severely hypoperfused, while the right side is well perfused. And after balloon angioplasty and stenting, we did again the technetium lung perfusion scan, which showed that now the right lung is also very well perfused in this patient. Patient showed marked symptomatic improvement in this patient. her dyspnea on exertion markedly improved. The cyanosis also disappeared, and as the patient was having high ESR, so the patient was having disease activity also, we continued their corticosteroids in this patient on long-term follow-up. Later on, as the patient was also symptomatic because of pre-syncope and syncope, we also did balloon angioplasty of this carotid stenosis for recurrent pre-syncope and implanted a stent. The restudy was, when we restudied this patient also on long-term follow-up, this showed that this patient had mild intimal hyperplasia and continued to be having relief from her shortness of breath. Now this patient has been in follow-up with me for the last 10 years and she continues to be asymptomatic. Cyanosis is relieved and the dyspnea is also relieved in this patient. In fact, this is the first case of pulmonary artery stenting to our knowledge in Takayasu's arteritis in the world. The patient was at very high risk of surgery because she had multiple arch vessel occlusions. All the major vessels of the going to the brain had severe stenosis, and any further interventions would have been a major risk for this patient. So balloon angioplasty in this patient gave a safe alternative to this angioplasty procedure and produced a marked clinical improvement. The intravascular ultrasound done in this patient showed dense transmural fibrosis of all the layers, which needed a high pressure dilatation, and after balloon angioplasty you can see dissection. Now we have one of the world's largest experience of balloon angioplasty in Takayasu's arteritis, where this type of treatment of balloon angioplasty is safe and very effective, but often there is dissection at the site of stenosis, and one needs a very high pressure balloon dilatation to open up this densely fibrosed artery as compared to atheromatous artery, which has just a fatty apposition which can be very well dilated to improve the lumen. But these patients have good improvement on follow-up. Recently, there was an editorial in the JACC on this balloon angioplasty for treatment of pulmonary artery hypertension. After this, our case, now this pulmonary artery angioplasty is being done in several other centers, and a series was published from China on, therefore, there was an editorial on this in JACC, which showed that pulmonary artery hypertension can be relieved in this patient of Takayasu's arteritis and is a safe and very effective treatment for this disease. Thank you very much for your patient listening.